Hello. On behalf of the Mountain Plains Regional Disaster Health Response System, I'd like to welcome you to this, our fifth in the Be Nice Weapons of Mass Destruction series. This particular module will discuss the bacterial biologic agents. The recognition of a biologic event is critical because of the potential for secondary transmission. Unfortunately, it's often delayed because of the incubation period associated with many of the biologic agents. So we're going to talk about the various types of biologic agents that have been weaponized for warfare purposes. We'll talk about the signs and symptoms of exposure and how to recognize them, and the use of appropriate PPE. Bioagents as a weapon actually have been used for a long time. You may remember that in the Middle Ages, when they would lay siege to a town, those laying siege would take the dead bodies of victims of plague and catapult them into the city in an effort to try and infect the sieged population. I mentioned previously that smallpox blankets were given to Native Americans during the French and Indian War. Germany in World War I tried to infect horses that were being shipped over to the European theater with glanders. Japan had an active biowarfare program in World War II, and Iraq in the 1980s has had a biowarfare plan as well. Now, while we're going to talk about biologic agents as relates to weapons of mass destruction, we should recognize that dealing with biologics is an everyday occurrence. There are a host of diseases that we deal with every day. And the reality is that if we can deal with all of the diseases and then some that are listed on this slide, we can deal with all of the biologic agents that have been weaponized and could be used potentially by a terrorist. Now, for terrorism purposes and use as a weapon, the size of the particle that contains the biologic is key. The ideal particle measures roughly 2 to 3 microns in size. Larger than that, the particle will become lodged in the upper airway and not necessarily create the desired disease effect. Particles that are smaller than 2 to 3 microns will be inhaled and down into the lungs and then promptly exhaled again. The issue with a 2 to 3 micron size particle is that is the ideal size to become lodged in the alveoli of the lungs to create the disease that is desired. Bioweapons release could have a huge impact if it's done in a way that spreads disease throughout a large population source. For example, this image shows a line source, a crop duster, if you will, spreading what could be biologic agent. If you had 110 pounds of anthrax spores, for example, and sprayed it along a 1.5 mile line source, upwind in a city of 500,000, you could potentially kill 24,000 people and hospitalize countless more. Obviously, that would have a huge impact on the healthcare system. It would cause profound psychological distress among the rest of the population. And this would be essentially the equivalent of a nuclear weapon. Now, this is a series of slides that were prepared by Northern Command in Colorado Springs, Colorado, a number of years ago. It simulates the release of Mnemonic Plague in a Las Vegas casino. The initial exposure involves 600 people. The very next day, some of those people fly or drive home, and that could be international as well as local. Second day after exposure, more people fly home and drive home. But now we start to see people getting sick. The red dots, the small red dots on this image represent the initial cases of plague. Day 3 after the exposure, additional people are going home, and we're starting to see increasing numbers of illnesses, both in the US and internationally. By day 4, the numbers have grown dramatically, and now we start seeing secondary spread. As you may be aware, pneumonic plague is one of the diseases that can be spread person to person. And we start seeing secondary cases, and those are represented by the green circles on this map. And by 5 days after the incident and the release, we see ever increasing numbers of cases, increasing cases of secondary transmission. And while this is dramatic, this is not out of the realm of possibility. This is precisely what a terrorist would hope to accomplish by releasing a biologic agent. Now, we need clues about how this agent was released, and epidemiology is key. So what are we going to look for a biologic release? Well, the relatively sudden appearance of large numbers of patients with a similar clinical illness. Excuse me. Many of the biologics present initially with a flu-like illness, fever, chills, aches, and pains, but it has a high case fatality rate. Immune-compromised patients may have increased susceptibility. We may see common disease syndromes, but higher than expected morbidity and mortality, infections that typically you don't see in a particular region, unusual seasonal incidents, multiple simultaneous outbreaks in multiple locations. The usual therapy is not effective. Sick or dead animals may be the first clue that something is going on. And in some cases, your terrorist may actually announce that they did it. Travel history, often an important component. Contact tracing is a key, particularly for diseases that spread person to person. Employment history may be important, and the activities over the preceding few days or weeks will help identify the potential location where the source was obtained and others could have been exposed. The CDC has categorized biologic agents into 3 groups, depending on the ease with which they can be weaponized and their lethality. The category A are considered the highest priority. That includes diseases such as smallpox, anthrax, plague, botulism, tularemia, and the viral hemorrhagic fevers like Ebola. And then second priority are the ones that you see on this slide. And category C are emerging infectious diseases and those that are much more difficult to weaponize. So in this presentation, we are going to talk about the bacterial agents. The bacteria, they're single-cell microorganisms. They typically will invade tissues and cells, cause inflammatory reactions. They may produce toxins, and some of the bacteria produce spores. The production of spores is an important consideration because it allows the bacteria to survive for a long period of time. And in fact, in one case, an artillery shell from World War I was opened up, and it was found that, in fact, it had anthrax spores placed in it. And those spores were germinated into active anthrax some 80 years after they were created. So let's talk about anthrax. Anthrax is a gram-positive spore-forming bacillus. As an infection, it's endemic in animals. It happens all the time, quite frankly. Humans develop infection from handling contaminated animal hides or animal fluids, and it has a name called wool sorter's disease. Anthrax can be obtained by inoculation, by ingestion, or inhalation of the spores. The spores then are attacked by macrophages attempting to defend the body against the infection. The macrophages carry the spores to regional lymph nodes. The spores germinate inside the macrophages and produce vegetative bacteria. And the bacteria then produce 3 toxins: edema factor, lethal factor, and protective factor. Edema factor does just what you think it does. It causes swelling. Lethal factor causes cell death. And protective factor is what allows the first 2 factors to work and attack the cells. Now, the inhalation route has the highest mortality, and if a terrorist was to use anthrax as a weapon, that would be the most likely route that they would want to use. The traditional teaching is that inhaled anthrax causes a mediastinitis rather than pneumonia, and the mortality from this is significant. Untreated skin infections have a 20% mortality if septicemia develops, but when treated, the mortality goes down to 1%. How do we make the diagnosis? Well, it's a clinical picture of sudden respiratory distress, and on chest x-ray, you see a wide mediastinum. That wide mediastinum basically is reflective of the infected lymph nodes in the mediastinum. A smaller number of patients may present with GI or cutaneous anthrax. A gram stain of the blood may reveal the bacteria, but these are late findings, so wouldn't depend on that to confirm the diagnosis. And then more advanced diagnostic testing can confirm the diagnosis, but samples typically have to go to a reference lab, and they take time. Here's several examples of cutaneous anthrax. In the left-hand picture, you see this dark, necrotic, swollen left right eyelid, the name anthrax is actually from the Greek word meaning coal, and you see that necrotic tissue that looks like a piece of coal. The right-hand photo, again, another picture of cutaneous anthrax. Look at the massive swelling associated with this infection, and then the necrotic spot just lateral to the lips. Couple more examples: anthrax on the neck, and again, that dark necrotic tissue. And here you see a sequence of photos on the right showing anthrax infection as it progresses from the initial photo on hospital day 5, a week later, and then several months after discharge as it's healing. Here's oropharyngeal anthrax. The left-hand picture shows the initial lesion in the posterior part of the palate, and then several days later, you see that it has grown in size in the right-hand photo. So inhalational anthrax typically has an incubation period of about 1 to 5 or 1 to 6 days. And then we have the onset of that flu-like syndrome, fevers, myalgias, cough, and fatigue. Then typically the patient feels a little better for a day or 2. And then you have an abrupt onset of respiratory distress, shock, and death follow quickly. The physical findings are nonspecific. The chest x-ray ideally would help if it shows you that widened mediastinum. And as you look at this x-ray here on the image slide, you see wide mediastinum representing those infected lymph nodes. And 50% of cases have an associated hemorrhagic meningitis. And as you might guess, those patients do poorly. Here's an example of GI anthrax. The left-hand picture is under ambient light, the right-hand picture under ultraviolet light, and you can see multiple areas of necrosis of the GI tract. Now, there was an accidental release of anthrax in 1979 at a Soviet military compound where they were researching biologic warfare and producing weaponized anthrax. The incident occurred when a filter in the facility became clogged. It was time to change it. They pulled the old filter out, but inadvertently failed to put a new one in because a shift change occurred. And as a result, anthrax was spewed out into the environment. The Russians admit to 66 deaths downwind. Here are autopsy pictures from two of the victims. In the left-hand photo, what you see is a lung, the trachea and bronchi. And as you look at that lung, you see it's totally black. It's totally necrotic. The right-hand picture is the cranial vault of a victim showing the hemorrhagic meningitis. Now, the good news about anthrax is that inhalational anthrax is not spread person to person. Therefore, we can take standard precautions once we know that it's anthrax. Cutaneous anthrax can be spread person to person, so contact precautions are required for that. Treatment for inhalational anthrax, it's the right-hand slide. This is the current recommendation for patients with meningitis. You see on the left-hand side the recommendation for therapy. There is a antibody treatment for anthrax called Abthrax and Anthem. These are monoclonal antibodies against protective factor, with the goal being inactivate protective factor so that the body can then deal with the infection. There is also an anthrax immune globulin. Now, again, should an incident occur, you'll want to check for the latest recommendations for antibiotics and treatment. If you've been exposed but not yet sick, prophylaxis, of course, is recommended. You see the recommendation here. There is a vaccine called Biothrax that can be used, and you can also administer the monoclonal antibodies. The vaccine Biothrax, it's used pre-exposure for those who are at high risk of becoming exposed, animal workers, etc. It's a 5-shot series over 18 months. If you're using it as a post-exposure intervention, it's a 3-shot series at the as soon as possible after exposure at 2 and 4 weeks, and then of course in conjunction with antibiotics. Pediatric therapy is what you see here. If you're familiar with doxycycline, you know, typically doxycycline is not used in pediatrics, but, and the reason for that is because it causes potentially discoloration of teeth, but that usually requires multiple courses of doxy, and for a single course treatment, it's not a problem. But again, you'll want to check the current recommendations in the event of an incident. You may remember the postal attacks that happened in 2001. A series of letters were sent to senators and news agencies, and the contents were actually remarkably well prepared. Anthrax, weaponized anthrax. The end result was that there were a total of 22 cases from this attack. 11 were inhalational, 11 were cutaneous. Of the inhalational anthrax cases, 5 died, 6 recovered. That's a case fatality rate of 45%. That is much lower than what is traditionally reported. Traditionally, it's reported that anthrax, inhalational anthrax, has a mortality rate of 80% or higher. And quite honestly, probably the improvements that we have in both antibiotics and intensive care treatments account for this difference. The cutaneous anthrax, all of those cases recovered for a case fatality rate of 0. Here's the presenting symptoms in the first cases. And as you look down this list, look at the first 4 or 5 presenting symptoms. This looks like the flu. Fever, chills, sweats, fatigue, malaise, lethargy, cough. Looks like the flu. Okay. Nothing at all specific about this presentation. If we look at the laboratory findings and physical findings, there's absolutely nothing that's specific that would help us make the diagnosis of inhalational anthrax. But if we look at the chest x-ray findings and CT findings, we see that all of the patients had an abnormality on their chest x-ray. Many of them had the mediastinal widening. I mentioned that the traditional teaching is that it's a mediastinitis and not a pneumonia. In fact, 2/3, almost 3/4 of the patients did have evidence of infiltrates and pneumonia, and pleural effusion was a common finding. Same thing is true with the chest CT. So while the traditional teaching says widened mediastinum, mediastinitis as the primary finding, recognize that infiltrates and pneumonia do occur. Now, plague. Plague, Yersinia pestis. It's a gram-negative, non-spore-forming bacillus. It is actually also a naturally occurring disease. Infected fleas live on infected rodents. They spread the infection to humans. And recovery does offer temporary immunity. Once again, once you are infected with the plague bacteria, macrophages attack the plague bacteria in an effort to control the infection. They carry the plague bacteria to regional lymph nodes where that bacteria reproduces, and it causes a regional lymphadenitis. After that, you can then get a bacteremia and septicemia. Plague, this is normal, sort of everyday natural plague transmission. We have the infected rodent, fleas bite the rodent, they can become infected, they spread it to a human. The typical result is either bubonic or septicemic plague. They may then spread it to others, causing pneumonic plague, and then secondary spread can occur after that. Plague is an endemic disease in the US. Every year in the United States, this left-hand graphic, every year in the United States, we have cases of naturally occurring human plague. And you can see there's an average of about 10 cases a year. The graphic on the right shows the distribution of plague in the United States. And you can see that it is a disease that is endemic in the western half of the United States. So having a human case of plague in Colorado or New Mexico or Arizona would not be surprising. Having a human case of plague in Georgia or Mississippi or Florida however, would be surprising. And that would be an epidemiologic clue that something's going on. When we talk about the naturally occurring disease, pneumonic plague is a small percentage of those cases. Bubonic is most common, and then septicemic lower down on the list. You can see the mortality rates for these diseases. Pneumonic plague, treated, has about a 60% mortality. Untreated, or if treatment is delayed, pneumonic plague has a mortality of greater than 90%. And that's the form that we would expect for bioterrorism. The bubonic form of the disease, treated, has a mortality under 5%, untreated about 50%. And septicemic plague, a mortality not insignificant, 30 to 50%, and again, greater than 90% if left untreated. Inhalational plague or pneumonic plague has a 2 to 3 day incubation period, followed by, that viral influenza type syndrome. High fever, myalgia, chills, and cough, and headache. That cough may be productive of bloody sputum. Pneumonia and sepsis develop acutely after this and may be fulminant, leading to circulatory collapse and death. Do a chest x-ray, you're going to see patchy infiltrates and consolidation. If you look at that chest x-ray at the upper photo, you can see that the right lung shows almost complete opacification and consolidation. The bottom photo is an autopsy picture showing multiple areas of infiltrates and consolidation. So, how's it start? Like the flu. Now, bubonic plague, interestingly enough, a bubo is essentially nothing more than a swollen lymph node. If you get bitten by that flea on your leg or on the arm, the macrophages will carry those bacteria to the closest lymph node. In the leg, that's going to be in the groin. In the arm, that's going to be in the axilla. This photograph shows you a bubo in the axilla of a patient that got bitten by a flea on the arm. You can actually stick a needle into the bubo, aspirate it, and do a gram stain that will help identify the plague bacteria. There are a number of other things that look similar to it, so you have to differentiate it. Couple pictures of bubonic plague. The one on the left showing the swollen bubo in the axilla. The one on the right showing the swollen bubo in the groin. Now, black plague. Why did they call it the black plague? Well, that's because the plague bacteria creates a cryoglobulin that gets activated when the body temperature decreases. And that cryoglobulin then causes microthrombi in the small blood vessels of the body. And this occurs in places that easily become cold. So that is fingers, toes, earlobes, nose, penis in males. This acral gangrene can be a late complication, and this is how it got the name, the Black Plague. Here's an example, again, of the gangrene that happens at distal parts of the body as a result of these microthrombi that develop in the small blood vessels in areas that are prone to becoming cold, thus activating that cryoglobulin, causing the blood vessels to occlude. Now, if you are able to gram stain a lymph node, aspirate, or sputum, or in some cases even cerebrospinal fluid sample, you may see the typical appearance of plague. Plague bacteria looks like a safety pin. So you see staining at either end with a relatively clear area in the center. And the red arrow points out several of these. Now, pneumonic plague, unlike anthrax, pneumonic plague can be spread person to person, and it's fairly likely it's infectious. So standard contact and aerosol precautions are required until you either exclude the diagnosis or cultures are negative. Now, the question is always going to arise, okay, I've got a patient who presents, they've got that viral-like syndrome, it could be plague, and it could be anthrax. What should I do? Treat them all as if they were capable of secondary infection and use respiratory precautions and aerosol precautions, standard and contact precautions on everybody until you have a diagnosis. If it turns out to be anthrax, you can then back off on the need for this. If it turns out to be plague, obviously then they'll need to be maintained until sputum cultures are negative. So plague, because it's infectious, if you're transporting the patient, maximize the airflow in the ambulance, isolate the individual respiratory-wise in the hospital for at least the first couple of days until treatment has been instituted and you know the cultures are negative. Care otherwise is supportive. There is a vaccine, but it only works for bubonic form of the disease. It is not preventive for pneumonic form of the disease. Prophylaxis is with tetracycline or doxycycline, and antibiotics need to be started as soon as possible if we're going to improve survival, and you treat them for a couple of weeks. The list of currently recommended antibiotics is there. Again, check for the most current recommendations. For children, the recommendations are there, but as always, double check with the health department. Tularemia, Q fever, and brucella. All of these are zoonoses. All of these occur in animals. All of them have a natural reservoir, and so they're out there. All of them are highly infectious. All of them can be weaponized. All of them present as a flu-like illness. The good news is that they don't spread person to person, and treatment is what you see on the slide. Again, check for the latest recommendations. So, plague, the primary bacterial infection that can be spread person to person. Inhalational plague is the form, pneumonic plague is the form that a terrorist is going to try and create. But since all of these biologic bacterial agents present in similar fashion with this flu-like syndrome, appropriate precautions and particularly respiratory isolation has to be taken with every case until a formal diagnosis has been made. Thank you for your participation, and hope you'll participate and look at some of our other modules.